Nail involvement is very common in psoriatic patients, and as we noticed in our practice, actually about almost 70 to 80% of patients with psoriasis have nail changes. Its prevalence is variable in the studies. It ranges from 10% to 80%, but the lifetime incidence of nail psoriasis is about 80 to 90%. This means that 80 to 90% of psoriasis patients will develop some nail changes in their lifetime. Regarding nail changes without skin changes, this is a big problem and it's a diagnostic challenge, and this happens in approximately 5% of patients that they develop nail psoriasis without any skin manifestations or psoriatic arthritis. Psoriatic arthritis, usually most of patients with psoriatic arthritis have nail changes, and it's considered that nail changes is a risk factor for developing psoriatic arthritis. So patients with nail changes, especially if there is marked nail changes, these patients are more liable to get psoriatic arthritis. When psoriasis affects nails, it can affect the nail matrix, it can affect the nail bed, or affect the nail folds or the hyponychia. It's very important to differentiate between nail matrix affection and nail bed affection, because the prognosis is variable, the impact on quality of life and treatment is variable if it's nail matrix or it's bed affection. The signs of nail matrix affection include bedding, crumbling, pleconychia, and red spot of the lunula. The manifestations of nail bed psoriasis include oil drop discoloration, onycholysis, subungual hyperkeratosis, and splinter hemorrhages. We will start with nail matrix psoriasis because nail matrix psoriasis have more impact on quality of life and more difficult to treat because it will manifest on the nail plate, and the most important sign of nail matrix psoriasis and nail psoriasis at all is the bedding. Bedding is one of the characteristic and specific manifestations of nail psoriasis, and it's usually presented with even size and depth, and the number of beds is variable, but there is minimum limit of number to diagnose nail psoriasis from bedding. You should have at least 10 beds in single nail, or at least more than 50 beds in more than one nail. This is regarded as proof of psoriasis. So bedding is the most characteristic and specific manifestation of nail psoriasis. Why bedding occurs in nails? Bedding happens due to parakeratosis, which breaks off when it grows out from the under proximal nail fold, then leaving these depressions. The next sign of nail matrix psoriasis is red spots. Red spots, as you see in the lunula, present very active psoriasis, and this is due to dilatation of the capillaries and thinning of the suprapapillary plate. The third sign is crumbling, and fourth is pleconychia. Crumbling happens when total matrix affection leads to complete destruction with crumbling of the nail plate, and pleconychia usually happens when the mid or distal matrix is affected and parakeratosis cells are incorporated into the nail plate, making it optically opaque. We will shift to nail bed manifestations. The first sign of nail bed psoriasis is splinter hemorrhage. A splinter hemorrhage is equivalent to ospit sign in the skin, and this happens due to either hemorrhage from dilated vessels in the nail bed or due to blood clots in the nail vessels. The next sign is oil spot. Oil spot also one of the characteristic lesions of nail bed psoriasis, and the oil spot very frequent, and it, as you see, it occurs as yellowish brownish spot with red margin, shines through the plate because of psoriatic squames are compressed under the nail and imbibed with serum. Finally, onycholysis is one of the nail bed manifestations, and Onycholysis usually happens if the sandbone spot or the oil spot reaches the hypomecium, and one of the typical manifestations of onycholysis due to psoriasis is the proximal red margin, and this is characteristic, and you can help you to differentiate between onycholysis due to psoriasis or onycholysis due to onychomycosis. Subungual hyperkeratosis may be thick and then no oil drop more seen, and it can be very severe to resemble Pachyonychia congenita. When nail folds affected, the nail fold can be affected in both the dorsal and ventral aspects, and the proximal nail fold results in swelling and rounding at its free edge, and this leads to spontaneous loss of the cuticle, and this is called psoriatic paronychia. What about the impact of nail psoriasis and why we give some importance for nail psoriasis in our decision in treatment? Its impact on quality of life, and actually any visible area in psoriasis have a special impact on quality of life, and fingernails are highly visible, and this will affect the patient too much and will be affected on different aspects of quality of life. And this additional negative effect can be increased by the associated symptoms of nail psoriasis, as nail psoriasis can be sometimes associated with pain, which is usually sometimes lead to inability to grasp small objects, to tie shoes lace, to button clothes, and this will give more negative impact on quality of life. Regarding the pathogenesis, as mentioned before, and it will be mentioned later, psoriasis is a multifactorial disease, and nail psoriasis is part of, or in the context of psoriasis, so it's not have a special pathogenesis, but there are some differences. Regarding the genetic element, we know that there is association between HLA-CW6 and cutaneous psoriasis. However, in nail psoriasis and psoriatic arthritis, most of patients are negative for HLA-CW6, which means that this is a genetic separate genotype. For triggering factors, trauma is considered one of the most important triggering factors, and most patients of nail psoriasis have some inflammation in the tendons and ligaments giving rise to enthesitis, so there is some sort of micro trauma, and this tissue stressing will lead to triggering of nail psoriasis. Also, for infections, Candida play a major role as a triggering factor for psoriasis generally and for nail psoriasis specifically. As Dr. Rasha mentions, that these triggers will lead to the release of self-DNA and RNA, which will mirror complex with LL37 and then activate plasmacytoid cells, dendritic cells, with release of type 1 interferons, 1 alpha and beta, and which activate myeloid dendritic cells, and then as a other sequence of pathogenesis. Another different in psoriasis, nail psoriasis, regarding pathogenesis is with what is called the immunoprivilege. We know that cutaneous psoriasis is characterized by down-regulation of IL-10. IL-10 is anti-inflammatory cytokine and immunosuppressive. However, in nail psoriasis, there is a difference regarding IL-10 expression, as IL-10 expression is increased in nail psoriasis, and this means that some sort of immune privilege for nail, and this is different from cutaneous psoriasis. Assessment of nail psoriasis is very important to have a valid assessment tool to determine the treatment of psoriasis, and until now there is no validated tool for assessment of nail psoriasis, and we are in urgent need to design a new index, and the most widely used is the NAPSI score. NAPSI score, we will not go through calculation, but it has some disadvantage, like its poor validation, and the lack of correspondence between NAPS score and the severity of the affection of nail, and also it not considering the quality of life in this assessment. There is another new index tool in the nail. It can be used, but we are still in need for more indices. Regarding therapeutic strategies, we have not too much therapeutic strategies for nail treatment, but we use usually the conventional treatment. But the most important is that we should start with patient education, and the prevention of mechanical or other trauma is very important, not only because trauma is one of the exacerbating factors, but because actually trauma will limit or have negative effect on treatment effectiveness. Nail psoriasis patients should avoid biting, tearing, and traumatizing the nails, tangential filling, frequently applying and removing the nail cosmetics, frequent water contact, artificial or gel nails, pulling, biting, and cutting cuticles, and also wearing high shoes and cutting toenails around edge. This is very important in treatment. When we will start the treatment of nail psoriasis, the most important factor is how much nails are affected. If we have few nail affection means that we have less than 3 nails are affected, or the NAPS score is less than 20. If this situation, we should differentiate if it's nail matrix or nail bed. If nail matrix involvement only, this usually the first line of treatment is intralesional injection of corticosteroids. If it's nail bed involvement only, the first line is topical steroid or topical vitamin D plus topical steroid. If it's combination, so we will start with intralesional of injection of corticosteroids. Whatever intralesional injection of corticosteroids is painful. This is the situation if the patient has no cutaneous psoriasis or psoriatic arthritis. So the patient has only nail involvement, few nail involvement with no or mild skin affection. But if the patient has severe nail affection or is associated with cutaneous or psoriatic arthritis, we will shift to systemic treatment. Conventional systemic therapies such as use of cyclosporin, methotrexate, retinoid have been shown to improve NAPS score in several studies, but whatever these conventional therapies have long time to have effect on the nails and also associated with organ toxicities. The next step to use biologics, especially anti-NF-alpha biologics. Anti-TNF-alpha family has been demonstrated to be reasonably safe and effective treatment of plaque psoriasis, psoriatic arthritis, and nail psoriasis. There are several clinical trials for use of anti-TNF-alpha in treatment of nail psoriasis. But actually we cannot compare because the methodology is different, the selection of patients and severity, the score used, but most of them are effective. Also the anti-IL-12-23 treatment, ustekinumab, anti-IL-17 maybe give a complete remission of nail disease. Also we can use small molecules, apremilast, or tofacitinib in treatment of nail psoriasis, and we can use non-pharmacological treatment, laser, especially pulsed dye laser, and we can use phototherapy, but for phototherapy, BOVA is only effective, but for narrowband actually is less effective or not effective at all. So this is our treatment algorithm. If you have mild nail psoriasis, 3 nails or NAPS score less than 16, you can use topical steroid or you can use topical
Dear
steroid
doctor,
plus vitamin
your time is up.
analog. If the patient have a combined skin disease or psoriatic arthritis, you can start with conventional treatment, but considering the long time to have effect and the organ toxicity, and after that, if no response, you can shift to biologics. Thank you so much.